Okay, so we've got some different hip movements. So if you move your hip, it's obvious, but they don't always go over it sometimes, and then people get confused. But if you move like your knee up to your chest, that's going to be flexion. If you move it back, that's extension. If you move it away from your body, that is abduction. And if you move it towards yourself, that's adduction. You can medially or internally rotate your leg. So it's like if you took your whole leg and like your toes go more inward, that would be internal medial rotation. And then lateral or external rotation is like where the leg is coming more outwards. Okay, so we've got some different nerves, and let me make sure that I have my chat box just in case I need it. Okay, so we're going to start first talking about these lateral muscle. We'll talk about lateral, posterior, medial, and anterior. And I took this again from Allie, so it's a little bit of like everything combined to one slide, which I liked. So the lateral compartment here is going to be innervated by superior gluteal, and it's going to be the function of abduction as well as that medial rotation, and that comes from our gluteus minimus, medius, and then the tensor fasciae lata. Now, what's different, the medius and minimus, they're doing this medial rotation, and they've got superior gluteal. I kind of think of them as higher up because they get superior gluteal, but gluteus maximus is going to be inferior gluteal. It's attaching farther down, and then it's doing extension. So the sciatic nerve is also back there coming out under piriformis, and then our hamstrings. Lateral rotation, our lateral rotators of the hip. Our nerves are going to be inferior gluteal, obturator internus, and quadratus femoris. So inferior gluteal, again, is glute max. We said it did extension, and it also does lateral rotation. Obturator internus, and the superior gemellus gets that obturator internus. So it's got that internus name, so it's the same. We'll talk about the order of these, and it kind of can help with the nerve innervation on another slide. And then quadratus femoris gets quadratus femoris as well as inferior gemellus. Okay, our medial compartment, we're going to adduct and flex, and it's innervated by our obturator nerve. And so we've got all of these adductors, so it makes it easy. In our medial compartment, there's lots of adductors, and that's our action as well. The flexors, they're going to be on the front. And so it sort of helps you, like if you're confused maybe in lecture or lab, like you can take your own body. I mean, I'm sure people have told you this, but you can take your own body and actually do those motions. So you can flex your leg, and if you feel like, if you start feeling the muscle tense up and you're like, okay, that's on the front. So that's that anterior compartment that does flexion. And so if you feel like your medial thigh, you're like, okay, I'm moving it inwards, and that those muscles, I know I'm adducting, and you're like, okay, so I get that. It can like sort of help you get the answer sometimes. The femoral gets iliopsoas, sartorius, and rectus femoris, and then the obturator again is getting these more medial. These are more associated with the medial compartment, but they have like a little bit of the anterior flexion as well. Okay, so we've got some important ligaments of the hip. It's really important to know what the difference between these are and what they prevent. So the iliofemoral ligament, first off, is also called the Y ligament because, as you can see, it like makes this Y. Let's see, let me get my laser pointer. Okay, you can see it better. So it makes this Y shape right here. And that is the strongest ligament of the body, and it prevents hyperextension. The ischiofemoral ligament also prevents hyperextension as well as medial rotation. And then the pubofemoral ligament, so right here from our pubes to the leg, we're preventing abduction. So if it gets stretched too far, if your leg is being abducted too much, then this ligament is pulling on it. So like doing the splits, you're gonna like feel some pain because of that pubofemoral ligament. So just make sure you know these actions of each one, because they could easily put just a first order question on there and say, okay, the patient is their thigh is being hyper adducted. What ligament prevents this? So that could be something like that. So there's this. If we take out the femur from our acetabulum, we've got this acetabular labrum that goes around it, and then there's this transverse acetabular ligament. So within this, it's like the ligamentum teres capitis femoris, and it's going to be traveling inside it with this obturator artery. The obturator artery gives blood supply to the head of our femur. And so if something happens to that artery, and later you'll learn, like not in MGA, but when you take MSK, you'll learn that like actually your obturator artery, it gets really tiny and kind of goes away. And there's some other arteries that anastomose that we're going to talk about. And they actually take the job of obturator as you get older. But it's really important as a young person or as like children, this obturator artery is what's supplying this head. So if there's no blood supply, it can cause necrosis and like break apart. So just make sure you know all of these actions. Okay, there's like three types of hip fractures. I don't really think this is important. Intracapsular, intratrochanteric, and subtrochanteric. I just don't really think that they would ask a question this way, but just in case they include one of these names in here, you know what, like in the question sim itself, they may not ask, okay, what type of fracture is this? But they might ask a question and put like intratrochanteric fracture. And you're like, what in the world does that even mean? Well, you need to know that it's like where this fracture is located, or if it's a femoral neck fracture. Maybe that could be a way that they could ask this question. Okay, so here's the artery supplying the femoral head and neck. So we've got the acetabular branch that came from the obturator. So make sure that you know that it came from obturator, gives off that acetabular branch to that head of the femur. The primary blood supply to the head is the medial circumflex femoral artery. So like it's the primary blood supply because the obturator is mostly for children, and then the medial circumflex is really what takes over. So if there is a femoral neck fracture, and so like intracapsular fracture, for example, there's a major risk of disrupting this medial circumflex femoral artery, and so there's not going to be good blood supply in order for that to heal. And then we also have this, the profunda, that just means deep, so deep femoral, where this is coming off. Okay, gluteal muscles. So these have like many names, but what most people call them, I guess, would be like the red carpet muscles. They're also called, the lateral rotators. Also, you could maybe have heard them called, somebody like put on our Facebook page last year something about like the lateral taters and put a picture of a potato. So they've got all sorts of crazy names. But these are the muscles that laterally rotate the hip, and they're located under our gluteal muscles. And so there's some different representations of them in these pictures. So here's our muscles. And in order, this is the way like I learned and remembered these, but it's P, go, Q. And if I put those in order, then I like know what order they fall into. And from there, I can figure out what the innervation is. So we first have piriformis. Now remember, above piriformis, we've got superior gluteal nerve, and then below it, we've got the inferior gluteal nerve. So we had talked about on this slide right here, superior gluteal is getting glute minimus and medius, and then inferior gluteal is getting glute max. So if I go back to this, you can see that gluteus medius is going to be attaching above piriformis, so it makes sense that it's going to be the superior gluteal. And then here's this glute max, and even though it is high up, it's also attaching below piriformis, so that's how I kind of remembered the difference between the two. But I think it's really important because it's things that students get confused. So if students get confused on it, that's something that they probably are going to ask more than likely. But the order of these are this P, go, Q. So piriformis, superior gemellus, obturator internus, inferior gemellus, obturator externus, and quadratus femoris. So the way that you know between these, like, G's, superior is going to be higher than inferior, of course. And then I kind of think, well, it's going to be internal before external. It kind of worked in my mind. I know it doesn't make total sense, but this obturator externus is one that's more deep and you can't really see it like in the picture. But I went ahead and put it so it shows all of them. So if you think back, I'm gonna go back to this slide. So this one, we've got, here's our lateral rotators. So our obturator internus, so we've got that P, go, Q. So P, we said was piriformis, and then obturator internus, it's getting this one, and it's also getting superior gemellus, where then we've got quadratus femoris, it's getting that one plus that inferior gemellus. So quadratus femoris and externus, and then obturator internus plus gemellus. Okay. So this is like fun fact. If somebody were to give a intramuscular gluteal injection, you want to make sure that you're missing the sciatic nerve and the other nerve, so you needed to give it in the upper lateral quadrant. So you miss those nerves and don't send the patient through the roof in pain. Okay, so we got a cruciate anastomosis. So anastomosis, big word, all it means is like some collateral circulation that takes place between these arteries. So we've got the internal iliac that comes down. It's giving off, remember, I think we had talked about this last week, the inferior gluteal artery. So our anastomosis, here's our inferior gluteal. It's coming down, and then we've got the lateral femoral circumflex artery and the medial femoral circumflex artery, and they are coming, circumflex just means around. So we're going around, remember that medial femoral circumflex, that is going to be coming around that neck of the femur. And then the first perforating artery of deep femoral, so there's perforating arteries that come off, and so we've got femoral, and then we've got deep femoral. So that first one coming off and wrapping around is that first perforating branch. And then all of these are, we've got the deep artery of the thigh So that deep femoral, and then of course we had talked about femoral artery as well. So our cruciate is inferior gluteal, lateral and medial femoral circumflex, and then that first perforating artery of the deep femoral. And they're all coming together right here at the neck. And I sort of remember this, but I know that on the practical, I kept coming, I know you guys have it different. I actually just found that out this week, but when we took the practical, it was kind of a free-for-all. You just went from like tag to tag. It wasn't like timed or anything. If anybody wasn't standing there, you just went to it. So anyways, I came back to this tag like 3 times and I couldn't figure it out. But then I thought about it, and there was an artery wrapping around the femur. And I noticed that it was more on the lateral aspect. So I thought that's got to be the lateral femoral circumflex. So just make sure that like you look at the things, use your context clues, think, okay, what direction is it moving? What is it going around? Sometimes it helps to look at another body and think, okay, where is this located in the body? Or if it's like an x-ray or something, you're like, okay, I see kidneys. What's close to the kidneys or something like that? If you see it sometimes in another cadaver, sometimes it helps you figure out the answer. Okay, so I really like learning about the leg and thigh as well as the arm in this compartment method. So I'm going to explain what this means, and it like makes it so much easier to learn all of the muscles, actions, nerve, blood supply, everything. So all of these muscles, as you've like noticed in lab, when you're dissecting, they come in this sheath. And so it'll be a big sheath around a group of muscles. So all of the muscles within that sheath, they have a similar, or at least most of them, typically will have the same nerve and same artery, and they will have about the same action as well. So I like to think like in general terms, what are the like blood supply and action of those muscles? Well, first off, what are the muscles? And then figure out, okay, I just have to learn, okay, all of these muscles are in the anterior compartment, and then learn for the anterior compartment, the femoral artery and femoral nerve, or what innervating is the blood supply for it. And most of the action is hip flexion, knee extension. If I know these, I can like then put in which muscles go with it, and I don't have to think, okay, sartorius does this, rectus femoris does this. I don't have to think of it in that way. So that's why I like knowing the compartments, and then from there, memorizing the muscle, like nerve, blood supply, and action becomes a lot easier. So anyways, just in case this confuses you, I just wanted to explain what it was. So in our anterior compartment, we've got the rectus femoris. That's that muscle that travels down the middle. And I'll show you pictures of all these. We've got the sartorius. That's the muscle that's going across to the medial portion of our knee. We have iliopsoas. We have vastus lateralis, medialis, and intermedius. So all of these guys are going to be innervated by the femoral artery and femoral nerve. And then innervated by the femoral nerve, and blood supply is the femoral artery. And so, but all of these don't do hip flexion and knee extension. So the only ones that cross 2 joints are going to be rectus femoris and then sartorius. But sartorius is doing a little bit more fun actions. It's doing that like hacky sack motion. So that the hip is going to, and I like just do it in my chair and it helps me. We'll have hip flexion. We'll have knee flexion. We're going to have external rotation of the hip, and we're going to have internal rotation of the knee. And I'm pretty sure we'll talk more about that. And then the vastus lateralis, medialis, and intermedius, they're only doing flexion of the hip. Okay, so our medial compartment are all of those adductors, and they're going to be innervated by the deep femoral artery, which remember came off of femoral, and then obturator, which went through the obturator, which we had seen when we were talking more about the reproductive stuff last week and all of the pelvic muscles. It travels with that obturator artery, and it's going to the medial compartment. And so all of these are innervated by obturator and deep femoral artery, except for pectineus that kind of gets a little bit of both. It's probably mostly femoral, but it gets a little bit of obturator because it's in the femoral triangle, which I've got a slide about. And so all of these adductors, and then gracilis, and then the obturator externus, all are right here in our medial compartment. Then our posterior compartment of our thigh, it's going to also get a blood supply from deep femoral, and then it's the tibial division of the sciatic. And most of the posterior thigh and leg get that tibial division. And then it's going to extend the hip, it's on the back, and then it's going to flex the knee. So we've got our boys to men muscles, which are biceps femoris long head, and then semitendinosus and semimembranosus. And semimembranosus is going to be on the medial side. It also starts with the M. Our biceps femoris short head, it's going, instead of going on the medial side with these guys, it's going more laterally, and it's going to be innervated by our common fibular division of the sciatic nerve. And our fibula is going to be on our lateral side in our leg, so it kind of makes sense that it's getting fibular instead of tibial. Just like a clinical correlate, that's not like super important now, but it will be. If there's pressure that's built up within these compartments, and this is why like it makes sense to think in compartments, because if there's a lot of pressure that starts building up, it can actually cause like an ortho emergency, and they have to open up these sheaths so all of these muscles don't like atrophy or become necrotic and then not usable. So it's a really, in a fasciotomy, they're just cutting the fascia to relieve that pressure. And so it would affect every muscle and affect the nerve and artery within that compartment. Okay, here's another way of looking at it if that's more helpful to you. That's what Allie made this slide and I made that one. So anyways. Okay, we had talked a little bit about fascia. So there's deep fascia of the thigh, and it's thickened more laterally, forming that IT band. And like they, like using this terminology. So thigh is the top, leg is below the knee, just so you know. Okay, iliopsoas. We had talked about psoas major and minor, and we had also talked about iliacus. In the last block, we said that they go down to the lesser trochanter, and as they're passing the inguinal ligament, it becomes the iliopsoas, basically. All right, femoral triangle. So you need to know the roof, the floor, and the contents of a femoral triangle. And so the roof would be that fascia lata. And then the lateral femoral cutaneous nerve, that's going to come out on the side, and that's causing that syndrome. If it's pressed on, then you're going to lose lateral sensation to the thigh. So that one's coming on the outside portion. Then on the inside, we've got our contents are going to be navel. So we're going to start with the nerve. So it's femoral nerve, femoral artery, femoral vein, and then E is for empty space, and then L is for the lymph nodes, which you don't see in lab. And then I couldn't remember, like when I was first learning this, what was lateral and which one was medial. So the way I remember it is there's got to be an L on both sides. So the lymph on the lateral side, it's not going to also have the L in navel, which is the lymph nodes. So they're going to be on the medial portion, where the lateral portion is going to start with that femoral nerve. So we've got two floors. We've got iliopsoas, and we had seen that iliopsoas over here in this picture. And so here is our iliopsoas, and then our pectineus is more on our medial side. I'd already talked about this neuralgia peristynica, which is that hipster syndrome, which is that compression of the lateral femoral cutaneous. And then also a femoral hernia, which is maybe not talked about as much, but it's just another indirect inguinal hernia that's passing, and it's coming through here and pushing on that femoral vein. Okay, on an MRI, here is a femoral hernia, and here is the pubic symphysis and the tubercles. Here's our ischial tuberosity, and then out here, more laterally, is the greater trochanter. On the very back, we've got our gluteus maximus. Okay, here's our anterior compartment of the thigh. So we've got this adductor canal, and we're going to, there we go. Let's talk about the muscles before that. So we've got our rectus femoris, which all of these muscles make up our quadriceps. So down the middle, we've got our rectus femoris. Remember, that's crossing two joint lines. It's going from our hip down to our knee. So it's going to flex, and it's going to flex the hip and extend the knee. And then vastus lateralis, intermedius, and medialis, they're just extending the knee because they start right here, so they don't come up as high. Our quadriceps tendon is what all of these are coming down and making one, pretty much one tendon that's attaching to our patella. And then from our patella down, we've got our patellar ligament, which sometimes people say it's the patella tendon, like if they get a reflex or whatever, but it's actually a ligament. Sartorius, here's that muscle that comes down that allows us to flex the hip, flex the knee, externally rotate the hip, and internally rotate the knee. I have to do the action, and then I know what it does. And there's our pectineus and iliopsoas that we had talked about with the femoral triangle. Okay. Pretty sure we've got more about the canal. Let's look at this medial compartment. Okay. So our medial compartment are mostly our adductors, with exception of gracilis doesn't have an adductor in it. It doesn't have adductor in its name. So that's going to be our most medial muscle. And the way I remember this is there's two people on a date, and the guy goes to put his hand on this girl's medial thigh, and she sweeps his hand away and says, "No, gracias." And so that's how you remember gracilis. So that's what I was taught, and I never forgot that. Sometimes those silly things help you remember things. So here's our adductor magnus. It's like a really big guy. A lot of these are like important to be able to identify in lab, but basically they're all going to adduct to the thigh, and then just knowing what that the obturator nerve innervates it, and the deep femoral is what is the blood supply. And this obturator nerve is coming out between the pectineus and the adductor longus. Okay, posterior compartment. Here's our boys to men muscles. And so here's our semimembranosus and the long head of the biceps. And then we've got semitendinosus. So semimembranosus, semitendinosus, and biceps femoris long head, that's our boys to men. And then that short head is going to be innervated by the femoral, the common fibular division of sciatic. And so this posterior compartment, that's our hamstrings. And the sciatic runs through it all across the hip and knee except biceps femoris. Okay, pes anserinus. So this is this compartment, or this is this area, it's not a compartment, sorry. This is the area that all three compartments attach to. And this is located on our tibia below the knee on the medial side. So the way that, and I didn't put this on the slide, but the way that you can remember what the innervation for these three are Sargent Foss. So S, G, T, and then F, O, T. Okay, so we've got our, first off sartorius, and that is going to be on our, it's on our anterior compartment, and it's innervated by femoral nerve. Then gracilis, that is our medial compartment, and it's innervated by our obturator nerve. And then we've got semitendinosus. Let's get that. There we go. And that one is going to be innervated by the tibial nerve. So that's another way of like knowing if you know this mnemonic and you know what other muscles are within these compartments, it can help you know what nerve goes to it. Okay, so here's the tibiofemoral joint. I don't really remember what it was. Maybe just that I thought it was like a fun name, but like Gertie's. Okay, is there a clinical correlate for PES? No, not really. I mean, it's called like Goose's foot. That's like not a clinical correlate. It's just fun. No, really, it's just knowing that they attach there, and that's about it. And knowing that something from all three compartments attach, and that's about all that you need to know as far as PES anserinus. I can't remember anything like super important about Gertie's tubercle except that it has a really fun name. And then we've got our lateral and medial epicondyles, and here's our adductor tubercle that our adductors are attaching to. Here's our patella that's floating on top, and then we've got a tibia, and here's our fibula located on our lateral side. And so some people call it fibulolateral. Okay, well, this writing is getting worse, but fibulolateral, and it can help you know it's on the lateral side. And here's our posterior side. Okay, here's some ligaments. I do remember this being an important image to know, and they can like ask you a lot of good stuff from it. So we've got our ACL and our PCL. And so our ACL, that is going to be, you're going to learn in EPC that you do this anterior drawers, and that it made more sense, like even though we hadn't done it yet in class, and we also did an LPP, but like we hadn't done that yet, but just knowing sort of how to do the test made it easier to know what the actions were. So if you pull the tibia forward, if the patient's knee is bent like this, and here's their foot, and you pull this tibia forward and their leg stays put, that's the ACL that's preventing it from just continuing on forward. So it's the tibia is moving forward, not the femur. If I push posterior drawer, if I push back, that's going to be the PCL. So the tibia is moving posterior on the femur. So a sneaky way that they could ask this is saying, if the tibia moves, or not the tibia, if the femur moves posterior, what ligament is like not working? Or if you push hard on the femur, what ligament is torn? Well, if I pull forward on the tibia, it's making the femur move more posterior. Yeah, so ACL, correct. So just make sure that when you're reading these questions, make sure that you're reading super close, because they could, ask a question about that. No, actually, I just noticed that my next slide is about the drawer testing. But anyways, you get a little extra right now. But our medial collateral ligament, and we've got a lateral collateral ligament. If you notice in the picture, the medial collateral ligament is really close to this medial meniscus. It's touching the medial meniscus really closely, and that's going to affect, when we talk about the unhappy triad, why that there's a problem right there. And then our lateral collateral ligament, it's not touching the lateral meniscus. It's out a little bit farther. So it's extra capsular, and it's the only one that's outside of that capsule. So since it's an exception, that could be something that they could ask you. Usually on x-rays, they'll tell you if it's anterior or posterior. they're pretty good about that. They'll tell you, or okay, they'll tell you if it's left or a right as well. They'll put something um, like they'll do one or the other. So they'll might do this. So I know that if I'm looking at a patient's right leg, the fibula has to be on the lateral side, and if I'm looking straight on at them, this would be like the right leg. Where on the other side, the fibula will be on the other side. So right in here between our femur and our tibia, we've got the meniscus. So our lateral meniscus, and then our medial meniscus. In the middle, right here, like at the front, is our ACL, and then more into the back is our PCL. So it looks more medially attached. Our MCL, of course, is going to be on our medial side, and on the lateral side, we've got our LCL. And so make sure that you look for that fibular head so you know it's lateral. Okay, here's the drawer testing that I talked about. So that ACL is preventing anterior translation of the tibia on the femur, or that posterior translation of the femur on the tibia. So that's what it looks like. So I'm pulling anterior drawer, pulling this tibia forward, posterior, I'm pushing it back. And like practice on your friends, and it'll make more sense. Okay, so we've got varus and valgus. So valgus we had talked about before because we had said like with women, their pelvises are shaped differently, so their femurs are not going straight down, so they're more of that valgus formation, so the knocked knee. And there's going to be more laxity of that medial ligament, the MCL. And then varus is more of that bow-legged, so I think of it as there's air in between here. And then valgus or valgum, there's gum in between the knees, so they go together. So our knees go together, so it's going to prevent, they're going to be like stuck together basically. And so the laxity is going to be on that inside, that medial, and then varus, there's going to be laxity of the lateral ligament. And you also need to know the Q angle. So there's a large Q angle with valgus, and then there is a low Q angle with varus, which is just the quadriceps angle. Okay. O'Donoghue's unhappy triad. So we'll have a rupture of the ACL, MCL, and medial meniscus. And it's because of a forced abduction or lateral rotation, like in a major injury like football in this example. So when we were looking at this picture, remember that medial meniscus and that medial collateral ligament, they're like basically fused together. So if one is going to be disrupted, it could easily disrupt another one. And then that ACL is just right there on the front. And there's actually more ACL injuries than PCL anyways, so it makes sense that it would be the ACL. Okay, so we've got different diseases. These aren't really important this year, but they do become more important next year. These are kind of just interesting things, so I'm going to move on. Okay, so we've got anastomosis now of our knee. We had talked about it of our hip and at the femoral neck, but now we're down to the knee. So we've got this, I thought a better picture of more of like that adductor hiatus. So we've got the canal, and now we've got this hiatus. And so it's this space where our femoral nerve is going to go through this hole and sort of change names. It's still the same artery, but it's just a name change. So we've got femoral artery, and now it's name changed to popliteal, and it's moved around to the back of my knee. So in EPC, you'll actually start feeling people's popliteal. It's kind of hard to feel, but you feel the popliteal artery and get a pulse from that. So here's our popliteal coming down, and then we're starting to get into the middle genicular, which is right in the middle, and then it goes down to our posterior tibial as it continues on down, and that's going to get our leg. So then we've got our geniculars that are going around. So on our medial side, we've got our superior medial genicular. On our lateral side, we've got our superior medial genicular. And coming down, our descending branch off of that lateral circumflex femoral. So we had talked about the lateral circumflex laterally wrapping around that neck and being part of our anastomosis. There's going to be a branch off of it, and it comes all the way down to our knee and gives off this branch above our knee going down into that superior lateral genicular. And then that goes and makes an anastomosis with inferior on both sides. And then we also get our anterior tibial coming off of inferior lateral genicular. So we've had a triangle, and now we've got the popliteal fossa. So we've got biceps femoris on our lateral side, and then semimembranosus is going to be on our medial side. It's got the M, and that is coming from our thigh. And then our gastrocs, gastrocnemius, medial and lateral head are going to be from our leg, and that is making up the borders of our popliteal fossa. So inside, we've got that popliteal artery that we had talked about coming through that hiatus from femoral, and then we've got our popliteal vein, and then that tibial nerve, which had come off of sciatic, as we had said, And then also coming off of sciatic. Sciatic basically is just a sheath of tibial and common fibular together. So if you like sort of cut that sheath, you would see two nerves. And sometimes on some of these different bodies, they've got like, you don't see any sciatic because it splits like pretty high up. But it's like textbook, supposed to split farther down here. And so here's our common fib. And then coming off of that, we've got our sural nerve, which is a cutaneous nerve, so getting that sensation to our leg. And then we've got our lesser or our small lesser saphenous, and that is draining into our popliteal vein, and then as well as some lymph nodes. So the floor of this is popliteus, and so that's like, so if we stand up straight and then pop our knee into, I guess like maybe pop is not the best word, but we lock our knee into place, that is popliteus. And when we unlock it, that's also the action of popliteus. They let us lock our knee and unlock it. Here is the top of plantaris, and it's like one of my favorite muscles for some reason. But I think it kind of looks, I don't know if you can see this, but I think it kind of looks like a tulip, which is a plant. And it's got this really long tendon that apparently people can like get confused and think it looks like a nerve. However, I'm pretty sure they like tell you 100 times that is not a nerve and it's a tendon. And also like you're dissecting, so you know. But anyway, this really long tendon looks like a stem of a plant, which is a tulip, the plantaris. Okay, so now we're getting into more compartments. Now we're going to talk about the leg, and this one is where it starts getting kind of confusing. So we're going to start with just talking about the blood supply first. So our anterior compartment is going to be the anterior tibial artery. Posterior is going to be the posterior tibial artery. And remember that was coming in this picture. Here's posterior tibial. It was coming down from popliteal to our middle genicular. Down now we're at popliteal. So, or posterior tibial, sorry. So our posterior tibial artery is going to be, of course, on the back. And so anterior tibial, that's another branch off of, that came from popliteal. Well, it came off of the inferior geniculars, which anastomose with all of them, but it's anterior tibial. So anterior tibial artery, anterior compartment, posterior tibial artery, posterior compartment. And then on the lateral side is our fibular artery, because our fibula is on that side. Okay, seems easy until we start adding nerves, because it's really easy to get these guys confused. We had talked about in the thigh, it mostly is tibial nerve, which came off of sciatic. And then there was one exception, which was the short head of the biceps, which was common fibular. So our tibial nerve is going to continue into that posterior compartment. And I literally would, like, on the test, I drew a circle, and I did it for the cumulative too. I just drew a circle and like put fibula tibia and drew the stuff out and wrote the blood and nerve, and it was easier and I didn't have to get them confused. So anytime there's a question on the test, I just referred to my diagram. So tibial nerve is in the very back. So then on our anterior, or let's go over here to lateral. So we've got superficial fibular nerve. So our fibula, I think of it this way. It's really superficial, or it's a pretty superficial bone. So if you go on the lateral side of your leg, like right now, and you start feeling down your leg from your knee, you feel that head. And then as you continue down, it's pretty superficial. So I think of it, so this nerve is superficial fibular nerve. We're going to have a branch that's going to go over and under some muscles, and it's going to the anterior compartment. So we've got the deep fibular nerve. So deep fibular is in the anterior compartment, superficial fibular is in the lateral, and tibial is in the posterior compartment. So what do these compartments do? So dorsiflexion is taking your toes and moving them towards your head, and then plantar flexion is pointing your toes, so like pointing them down to the floor. So what I would sort of normally think of that. So like some people get confused between dorsiflexion and plantar flexion. So plantar is the bottom of your foot, so you're planting them down. Dorsiflexion, moving them towards your head. So the anterior compartment, they are, and if you like just feel it on your leg, you feel those muscles tense up when you point your toes upwards. So that's innervated by deep fib, blood supply, anterior tib. Then our posterior compartment, they're going to do the opposite. They're plantar flexing, and then they're going to do some inversion as well as flexion of the toes. And then the anterior compartment is going to do a little bit of inversion as well. And then the lateral compartment, I just think of it kind of as like if I were to have a piece of string on the side of my foot and I just pull it up, it's going to just move, or like pull one of those muscles on the lateral part, contract that muscle, make it shorter. It's going to evert my foot or move my foot outwards. So invert moves it inwards, so together, evert moves the foot outwards, and then as well as plantar flex. So anterior compartment, we've got tibialis anterior, extensor digitorum longus, extensor hallucis longus, and fibularis tertius. And then on our posterior side, we've got our gastrocs, and that's popliteal artery. And remember, it's part of the popliteal fossa. two of the borders, medial and lateral heads. We've got our soleus, our plantaris, and then our popliteus. And then we've got our Tom, Dick, and very nervous Harry. So we've got tibialis posterior, we've got flexor digitorum longus, and then we've got flexor hallucis longus for Harry. So Tom, tibialis posterior, Dick, flexor digitorum longus, and nervous, that's tibial nerve. Oh, A is for posterior tibial artery, and then nerve, tibial nerve, and then Harry, flexor hallucis longus. So in lab, if you look at the medial malleoli and look under it, Tom, Dick, and nervous Harry, they're in order. Harry is more deep. It's kind of under everything else. But these are the order from the malleolus down to the sole. And you can figure out these. Now, the way that I remember the anterior compartment, so we've got tibialis posterior, and that's going to be right beside our tibia, and then our tibialis anterior. So they kind of mirror each other, and I'll show you on some pictures. And then our fibular side, or our lateral side, is just fibularis longus and brevis. Okay, here's our osteology, again, for you to review. So lateral malleolus is on the outside, and medial malleolus is here on the inside. So here's this lateral anterior compartment. So right on our tibia, we're going to have that tibialis anterior right there. On the other side is tibialis posterior. So that's how I'm meaning that it's sort of mirroring each other. And then our next one is going to be extensor digitorum longus. And then on our on our posterior side, we're going to have our flexor digitorum. So it's kind of how it goes in that order. And then we've got extensor hallucis longus, where we've got a flexor on our posterior side. And so remember, we've got our anterior tibial artery and our deep fibular nerve. Here's the superficial portion of our posterior leg. So we've got the gastrocs. And then soleus, if they were to just cover up this portion of the leg and then also the knee, and they say, what is this muscle? You would be able to say that it's soleus because the tendon of plantaris has to come over soleus. So it goes in between the gastrocs and soleus. And so soleus is right under that plantaris tendon. Okay, here's our tarsal tunnel. So we've got that, we can get that tarsal tunnel syndrome, which compresses the nerve and causes heel pain. So here's our Tom, Dick, and nervous Harry. So tibialis posterior, flexor digitorum longus, posterior tibial artery, tibial nerve, and then flexor hallucis longus. Okay, our lateral compartment is just fibularis longus and fibularis brevis. And so the longus has a longer tendon, and also the brevis is kind of underneath that fibularis longus. And this is on our lateral side. Here's our lateral malleolus. And then we've got the superficial fibular nerve, which innervates it, and which came off of that common fibular nerve. And then the artery is going to be the fibular artery. Here's about compartment syndrome again. Okay, so the blood supply we've already talked about a little bit about, but here's where everything's coming off. So on our posterior side, because I feel like it's easier, we've got this posterior tibial that's traveling down, and then we've got fibular that's coming off of it to go to that lateral side, into that lateral compartment. On the top of our foot, we've got the posterior tibial. Remember, it's going in that tarsal tunnel, going under our medial malleolus. And so you can collect it, you can get a pulse right there. And then also as it comes across the foot, you're going to get dorsalis pedis. And sometimes you can feel that best between the first two toes. So you'll have to be feeling some pulses later in lab. On the anterior side, we've got this anterior tibial. And then here's a perforating branch of the fibular, shown right here. Okay. Venous drainage. So here's the most important things that you need to know about the veins. You've got a great saphenous, and then you've got a lesser saphenous or small saphenous. So this lesser saphenous is going to be coming on the back of our leg, and it's going to be traveling up and going into the femoral vein. Where the greater saphenous is more on that medial aspect, kind of the front, but more the medial, and it's going to be traveling up, and it drains into the external iliac vein. So know what these two drain into and know the difference, like if they tagged one versus the other. Varicose veins are just big old large veins, and their valves don't really work, so you get backflow of blood. Okay, so we've got this sensory innervation of our lower limb, and sometimes, I mean, to be honest, sometimes you can answer the questions without knowing that cutaneous sensory innervation, but it's just easier if you go ahead and learn these things, because you'll have to know them at least at some point. So we've already talked about the lateral cutaneous nerve, FemQ, lateral femoral cutaneous, on that lateral aspect. On the internal aspect is obturator, which we had said was the motor also for our medial compartment of our leg. And then on the anterior side is just femoral nerve, and we had said the femoral nerve gets the motor portion as well. On the back, we've got posterior cutaneous nerve of the thigh, getting our posterior thigh. On the lateral leg, we've got our common fibular nerve. And then as we go down, it's our superficial fibular. And then on our more medial side is the saphenous. And then this purple color is our sural nerve. And then our tibial gets our heel. And our deep fibular gets between the toes of our first and second toe. Okay, so that is all my slides.